Good evening, everybody. My name's Craig Merrill. How are y'all doing? I'm the Vice President of Sales for Transcend Biologics, and we appreciate you taking the time to jump on our webinar tonight. We're covering the lower limb sports injuries and techniques for protocols of effective recovery with Dr. Frank Johnson, who's the President of CEO of SMU, which is Sports Medicine Ultrasound. If you've been on one of our webinars before, you're familiar with him as well. We covered upper extremity last month, and so this month we are doing lower extremity. So I'll wait just a moment and make sure that everyone is jumping on this before we get rolling.
Hey, Craig, so I have been very, very remiss. I have not watched college football much this year. How are your Arkansas Razorbacks doing so far this year?
Well, so first of all, I'm wearing the Razorbacks right now tonight, but I just want to let you know that the Razorbacks have come out with an NIL deal for the fans. They're just trying to pay fans to support the Razorbacks now because they're so terrible. So I'm waiting on my check from the University of Arkansas just to continue to support that terrible football program that we have.
Well, that's okay. We have basketball to look forward to.
Yeah, we have basketball. But I live here in Oxford, Mississippi, so I can cheer for the Rebels, and everybody around here is waiting to see if the Rebels knock off Alabama to get in the playoffs, or does Alabama knock off the Rebels? So we'll see.
You gotta be careful where you say that in that state, man.
Man, I'm a neutral party. I'm just a neutral party. I'm just a spectator here. But anyway, all right. Well, we'll get going, everybody. Welcome to the webinar. As I share my screen, I think everybody can see this, and if it will actually advance. So tonight we have Dr. Frank Johnson, MD. You can see what his experience in education and training is as well with that one. So a little bit about Transcend and the partnership that we have. So Transcend is not new to the PRP world. Back in 2013, our company was Eclipse, and we launched a PRP platelet-rich plasma underneath the brand Eclipse PRP in North America. We've done over 1 million cases performed over a 10-year period. And in 2022, we decided to get acquired. And so when they did, we birthed the principles, birthed Transcend Biologics. And we are focused on the fields of orthopedic, sports medicine, pain management, and PM&R. And now we're partnering with Ysonic, and that's why Dr. Johnson is so important to us. Because he is a guy that's probably used almost every single ultrasound machine known to man that I know of. I think you've tested all of them out. And so if you want more information about ultrasound and MSK, you can go to transcendbiologics.com as well for that. Our focus is orthobiologics, and so we thought the three components that really match well with our PRP is ultrasound and shockwave technology. So for more information, you can go to our website, or you can ask questions at the end of this as well. We focus on high concentration, minimal inflammation. We have a vacuum blood draw. We have a 10-minute centrifugation, and then we extract PPP. So within a 22 ml blood draw, you're getting about 11 to 12 cc's of plasma with platelets. And within that, if you want to inject like a 5 cc injection, then you can pull off your plasma pour and then go ahead and collect just your PRP toward the end. It's just a little diagram to show you. If you're looking at this, most of your platelets are sitting down by the gel as we run a gel separator. So you're looking at about 3 to 4 billion sitting on top of the gel. The other ones are floating in this plasma pour up here. And so if you wanted 5 times more on a single spin, then you would use 42 mLs of blood draw for that. And then just a quick comparison, Transcend, we did a comparison of 20 ml Buffy coat systems, so Arthrex, Insight, and Harvest. They all run a Buffy coat system. We run a gel separator technology. And within that, with 66 mLs, we're at 12 billion platelets on that. And so that's a little bit about Transcend. And I will turn it over and stop sharing my screen and turn it over to Dr. Johnson.
Excellent. Well, Craig, thanks so much for the introduction. I have run in the past 4 years, probably, I don't know, I'm going to pick a number, probably about 200 webinars, but every single webinar is a little bit different. So thanks so much for joining. And every single webinar sometimes has some technical issues. So if there's any technical issues, please bear with us and we'll jump onto the backup plan ASAP. But I am a family medicine doctor by training, and then with additional training, sport med doc. And then I got into this ultrasound gig because I thought, why do I have to work so hard to find really good, really focused ultrasound training programs? So I just developed the program that I needed way back when. So I have an amazing team in Canada and in America. Over the past 5 years, we've been able to meet a ton of amazing, invested, really eager docs that just want to do the best thing for their patient. Now, I'm up here in Canada, but I teach our courses in the States as well. And we have really enjoyed the partnership with Transcend. So if you are a medical doctor or a nurse or a PA or an orthopedic surgeon, or anybody watching this, you are allowed to inject PRP without any additional certification. The thing is, you need to have the skill. Okay, so your basic license allows you to inject cortisone or inject lidocaine or inject whatever vaccines, but it also allows you to inject PRP, but you still need to have the skill. So you need to understand, what on earth are we talking about? How do you select the patient to do it? Because like anything, our job as practitioners is to take the patient, ask them a bunch of questions, and figure out what's the best treatment for this specific patient, this specific condition, with the goals the patient has at the forefront of their mind. And I'll be honest with you, sometimes that's not PRP. But when it is PRP, we want to be able to identify it and treat them as effectively as possible. And then we also have to then do the procedure as accurately as possible. So what we have is we have a free Learn to Scan course all online, a free Learn to Diagnose course all online, and a Learn How to PRP course. That's all online at sportsmedus.com. It takes you over to this thing here. Our website, the way you would find it is you go to sportsmedus.com. You can do it afterwards. Pay attention to the website, to the webinar now. But you click on the online, look for webinars. The free courses, the PRP courses, it's all there, sportsmedus.com. When you get into the online PRP course, it looks like this. It includes a bunch of the paperwork, because we know that medicine runs on love and understanding and paperwork. So here's all the paperwork that you'll need, including things like treatment cards. So what does the patient need to take away from the office to understand how to prepare for the procedure? So for PRP, we don't want you to be doing NSAIDs before or after, as an example. And then I've got a ton of patient-reported outcome measures. These are all free to access, but these are all in one. When I say free to access, you could Google this. You could Google the IHOT 12, but we've put them all in the same place. Now, what you cannot access free, well, I suppose you can on YouTube, but I've tried YouTubing stuff, trying to figure out how to do a PRP injection for an Achilles tendon or something. And what I found was old videos from 15 years ago, shot with a crummy camera, and you can't really see what the doctor's doing. You can't really hear what the doctor's saying. So in this online course, this is the paid version, the online course, I have 25 demonstration videos of me in my clinic treating real live patients. And this you're not going to find on YouTube in a comprehensive, all in one place offering. So that's what you can get on our courses. Now, live course. So obviously you can't learn to scan very well online. You can get started with how to interpret the image, but we're running a live Add PRP to Your Practice course in Dallas, February 8th and 9th. It normally it's $1,695, but we're offering it for only $1,295 US. And it also includes our online course with all those videos I just talked about, which is normally $495 US on its own. So once again, a 2-day course for $1,295, which includes this. So it's quite a good value. We're also starting to offer courses to podiatrists because I realized there was a big gap in patient care for podiatry. So the podiatry course is a full day, 2-day course, which includes practice on cadaver specimens. And there's the price there. What you're going to learn if you're a podiatrist watching this course is you're going to learn all these things on day 1, and on day 2, you start practicing on the cadavers. But let's dive into the course. So what I've got here on in this paid course is a buyer's guide. I think Transcend is a fantastic product at a fantastic price. But you don't have to take my word for it. I've done the math. I've done all the hard work to add all this stuff together so you can compare all in one go about why Transcend is such a good value and why it does an excellent job to deliver an easy to prepare PRP preparation that your staff will love. My staff at my clinic have used 5 or 6 different preparation methods over the years, and these gel separator tubes are by far their favorite and easiest and most reproducible to prepare. So during this presentation, we'll go through the leukocyte poor. I tend to call it yellow PRP because it looks mostly yellow. Now, leukocyte rich winds up having some red cells in it, so it looks a bit more red. So I tend to think about leukocyte poor yellow, leukocyte rich red. Now, there's a few areas where that doesn't exactly hold true, but it's a nice, easy way to think about it. So how on earth does the Transcend product work? Well, when I met Michael in Pensacola, Florida last year, he was able to do a nice video for us about it. One of the beautiful things about the Transcend platform is, like I said, we've had maybe at least 5 different systems in use in our office, and Transcend's the only one to offer an online university, an online training program for its users. I haven't seen this from any other PRP provider. So for example, what happens if the gel fails? Because there's no one single product on the market that's going to perform perfectly every single time. So what do you do if there's a gel failure? What do you do if you get a cloudy PRP? What do you get if the PRP looks pinker than you expected? So I think this is a great reason, one of the Transcend advantages. Now, how do I choose who's going to benefit well from PRP? Well, I simply have to have a system. So the system we teach at Sports Medicine Ultrasound is the following. Patient comes into my office and says, I want PRP. I say, do you want PRP or do you want your Achilles tendon to feel better? They say, I want PRP to make my Achilles tendon feel better. I go, great. I said, have you done something like acupuncture or shock wave? And if they say no, I'm like, great, let's talk about those. If they say yes, I say, fantastic, let's move on to cortisone. And they go, well, I heard that cortisone was really bad and might rupture my Achilles tendon. I say, absolutely. But you can put it in the retrocalcaneal bursa. And if you have a really important trip to Europe coming up and you just have to be able to walk 10,000 or 20,000 steps a day, cortisone might be something we can consider. And they say, well, my trip to Europe isn't coming up for 3 months. I say, game on. This is a PRP case then. Now, up in Canada, we have hyaluronic acid for tendons, but in the States, it's not FDA approved. So we're simply going to jump forward to prolotherapy or PRP. So I say, look, your trip to Europe isn't for 3 months. Here's what I think we should do. I think we should hit you with PRP now, today. Let's not delay. I say, have you had any Advil in the past couple of days? They say, look, I had one yesterday for a headache. I say, hey, no problem. That's not going to be a barrier to doing PRP today. I then hit him with PRP on day 1. I then, a week later, get him back with the physios to start eccentric training exercises. I put him in a heel lift with a 8mm heel lift. And then I hit him again at the 3 or 4 week mark. So by the trip that's coming up to Europe 3 months from now, they're probably going to be feeling a heck of a lot better. And if not, well, then maybe we can talk a little bit about, say, let's get you a better heel, a different heel lift. Let's make sure you got some Hokas instead of your crummy old whatever shoes you're wearing. Maybe I'll put in 3 milligrams of dexamethasone or 8 milligrams of triamcinolone or something to the retrocalcaneal bursa. But this is the system that I use to treat my patients. I offer them stem cells and I say, look, I don't think the stem cells are going to get you anything better than a couple of PRPs. Obviously, we can do surgery, but that's not going to help you at all because you got a trip coming up in 3 months. The joints are exactly the same thing. I say, have you done physiotherapy or bracing? We move on through cortisone, hyaluronic acid, PRP. Just this afternoon, I had a lady come in and her orthopedic surgeon said, I don't want you to get any more cortisone in that osteoarthritic tibio-talar joint. I want you to do PRP. She came into me. We talked about the options. For her, hyaluronic acid for the tibio-talar joint seemed like a better option for the injection today. But if it doesn't help that much, in 4 weeks, we're going to circle back around. We're going to do 2 PRPs. So I have a system that I think really helps me not jump around and just do whatever the patient wants, because that's not always the right answer. In the course, we always talk about providing the best patient experience. So I think that a disappointed patient with PRP is highly unlikely if patients know that there's probably no insurance coverage and it might take up to 3 sessions. You let them know that, they're probably going to be good. I also think you need to let people know that if they get heat and redness after a PRP injection, no Advil, you can only use Tylenol, and please try to avoid ice. So there's lots of things that we run through in this course. I won't spend too much more time on this. We will move on to the protocols for lower limb, but I do think it's super important that I say, I want you to try and lighten your schedule for 1 day after treatment. Please arrange for a driver, particularly for lower limb things. Well, why? Is because my first ever PRP was a 55-year-old guy with moderate knee osteoarthritis who was going to go from my clinic to the airport to fly 3.5 hours to Phoenix to do 72 holes of golf over the next 3 days, including probably 72 beers. And I said, hey man, like, I don't know if this is the right fit. Maybe we should reschedule this for when you come back. So in the course, we go through all these things, but not only the instructions, but also the justification for those instructions. So I'll rip through this and let's look at what is a normal response for a tendon. And I'll say, look, there's nothing that's normal. I'll see people fall into 4 different categories. So those 4 categories are as follows. I'll see people who come in with a 6 out of 10 pain for their tennis elbow or their Achilles tendon. And I do the PRP injection and I tell them your pain will go up. The next time I make this chart, when I want to redo this, I'll take the pain from 6 out of 10 up to about 8 or 9 out of 10, because it can be really quite uncomfortable in a lot of cases. Some of those cases will respond very rapidly, and I'll say, look, you may wake up tomorrow and have no pain, but that would be highly unusual. We would certainly call you a fast responder if over the course of 8 weeks, your pain went down significantly. 0, I don't know, but you're going to be a fast responder if it comes down quickly. Most people are average, right? So there's going to be medium responders. So I set the expectation that it could be 16 weeks before they see a significant improvement. And then, of course, there's slow responders. I had one guy one time, he said, about the 6-month mark, I just turned a corner. Like, it was slowly improving. And around 6 months, wow, there was a huge change. So then me as a skeptical clinician, I'm like, well, maybe there was something else at play. But when somebody's had an Achilles tendon problem for 5 years, you do PRP, and then 6 months later, they're a lot better. You're like, well, maybe it wasn't a coincidence. Maybe it was the PRP. And then, of course, there's going to be people who think they improve and then they worsen. You go, yeah, you know what? That case, it just didn't respond. So rather than talking in absolutes and saying, absolutely, your PRP is going to help you a ton, I know it, I just don't think that's the most genuine way to approach the patient encounter. Here's a study that was done. It was actually done by, I think they were using the Arthrex ACP system. So a PRP system that produces way fewer platelets than the Transcend product. And I know this because I've tested it. I know this because I've read the Arthrex white papers. What they did in this specific paper was they injected people with moderate knee arthritis at the first visit, another injection 1 week later, another injection 2 weeks later. They blinded them, and half the people got PRP. The other half of the other arm got normal saline. So what they saw was that both the PRP group and the normal saline group had a reduction in their pain. But around this 2 month mark, that's when the pain from the saline arm started to rebound, and the pain from the PRP injection group continued reducing all the way up to 12 months. So I'm not personally in the habit of injecting, week 0, week 1, and week 2. But this is a really telling story that, look, you can inject anything into a knee joint and you'll get some reduction in pain, but you want long lasting relief that I can say, hey, look, this paper showed a pretty good improvement. This is an argument for sort of stacking PRP. So what is some of the other evidence? So what I did in this course, I looked at some of the patient education material that I used. So let's move on to knee arthritis. So these were some of the patient education materials that I made in my office. I printed them in brochures and I handed them out to patients. So what I did was I looked at a study. So for example, this one was done in 2017 in Boston. I included from PubMed, I included the synopsis of the study. And then I just made a very, very simple graphic version to say, hey, in this study, triamcinolone was bad and normal saline was good. So what they did was they took 70 patients, and over 2 years, they followed people who got 6 doses of cortisone over 2 years. That's not much. In my community, we'll say, look, we can inject cortisone every 3 months. So once again, this was 6 doses over 2 years. And then they tracked people. They did an MRI prior to the cortisone, and then 2 years later, they re-MRI'd their knees. And what they found was that the people who got 6 doses of cortisone lost more cartilage than the people who got saline injections. So the people who, there was lots of criticism of this article, but they're like, this is a really well-designed study, and they found less cartilage in cortisone. So you can look at this and say, look, I don't think cortisone is a horrible idea, but I definitely think it's going to be more harmful to your cartilage than doing nothing, doing saline, doing PRP. And so this is an argument against cortisone, and my patients sort of gravitate to that. This was a study done in, actually, this was the one I just showed you, that graph. This was the study where they found at the 2-month mark, the 6-month mark, and the 12-month mark, an improvement in patient WOMAC score. Another one was done in Malaga, and they said, well, you could probably get the same with anything. And I say, sure, okay. So what they did in Malaga was they looked at hyaluronic acid versus PRP. And they said the hyaluronic acid sort of had an improved patient function in these higher grades of knee arthritis, and the one where PRP didn't do quite as well would be grade 4. So this is where it's important, I think, to select your patients, because patients are going to come into you saying, hey, I heard this PRP is great for knee arthritis. You get an x-ray and they got severe Kellgren-Lawrence grade 4 knee arthritis. You say, look, I think we can do the PRP if you want, but maybe PRP isn't the best match for your grade 4 knee. It's probably a better match for your grade 3 knee, the other knee. So this is where in the course we help you through the patient selection. And this was a paper that looked at Monovisc versus, this was hyaluronic acid. I don't know what hyaluronic acid they used versus PRP, and they were equal. So I can't sit here and say to you that PRP is better in every single case. Not at all. I think you have to find people that respond to PRP. I find people that respond to PRP well are active people rather than passive people. So my athletes that come in seem to respond better than the simple office workers who don't do any, much physical activity. So that's lost papers. Let's look at one for Achilles tendon. So Achilles tendon is I think one where a lot of time I just don't have a lot of great options for them. So what this group in Italy did was they just said, hey, let's just track a bunch of patients over time. And they found that PRP showed benefit without a single rupture over the course of up to 7 years in some patients. So I can say, look, I can't promise you that PRP is going to make your Achilles tendon better. But if we give you a heel lift, take away footwear that compresses that painful Achilles tendon, we get you on a strengthening program, we do PRP 2 or 3 times. I feel confident as a clinician that that's the best, most tissue positive treatment I can possibly do for you. And I think it's safe, and I know it's safe. This other study was done with a smaller group where they actually showed resolution of many of the ultrasound abnormalities by the 6-month mark. Now, I do not tell people that they're going to get an improvement in their ultrasound. In fact, I say your ultrasound is going to look the same over time. But once again, I mean, this was one study that said, well, with some of the smaller findings, we did see an improvement in the ultrasound scan. This is sort of the contrarian argument. This was a paper published in the British Journal of Sports Medicine in 2011. It was done in Rotterdam, and the people on here, De Vos and De Jong, have published a ton of PRP papers over the years. And what they found was that when you included exercise seemed to be the most important thing. So I tell my patients, look, I can either get you on an exercise program alone and inject saline, which might be a placebo, or I can get you on an exercise program and actually put in the real juice that is blood that's going to help get in there, put in some growth factors, increase blood flow, and increase the health of the tendon. And when I show these people this paper, they say, all right, let's do the PRP. And I kind of understand the importance of the exercise that the physiotherapist is telling me to do. Plantar fascia. So if you're a podiatrist or you're a family doc or you're an orthopedic surgeon and you see stubborn cases of plantar fasciitis, you are not alone. We've got a podiatrist from the Mayo Clinic who teaches with us. And my first call with her, I said, you've got to teach me your secrets for plantar fasciitis. And I could hear her roll her eyes over the phone. She's like, oh, it's just so stubborn. So if you find plantar fasciitis is stubborn, you are not alone. But this is a paper that looked at 21 patients over 6 months. They said, hey, look, whether you want to do dextrose and fenestrate the plantar fascia repeatedly, or do PRP and fenestrate the plantar fascia repeatedly, you might get similar results. Definitely, I say, look, I do not want to do cortisone in this plantar fascia. It's going to decrease the collagen health in the plantar fascia, increase the likelihood you're actually going to tear. And the patient says to me, but I'm going to Europe next week. And I say, ugh, okay, this is not a PRP case. I will grudgingly do 10 milligrams or 15 milligrams maximum of Depomedrol or Kenalog adjacent to plantar fascia. In some cases, I will put it into the plantar fascia if I think that's the only thing that's going to work. But when you get back from your Europe trip, we're doing PRP twice. I'm probably going to put you in a boot after the PRP. I'm definitely going to give you some codeine or even some oxycodone because it's going to hurt a lot, but it's the best thing I can do for the health of the tissue. And obviously, I've got people who do plantar fascia PRP and they do great, but I usually want to warn them, like, this is going to be a long road. It's been a long road getting here. It's going to be a long road getting out of here. So this is where people come back and they say, hey, look, I've had plantar fascia injection with cortisone twice. Can't I just do it again? I say, sure. But here's a paper that was done in the UK that said, look, in the long run, the PRP was superior to cortisone. You've already had it twice, but we should really try something else. So these papers that are included in this online course can just help you. Like, why reinvent the wheel? I've done all the work for you. You've got these patient education materials that you can print off and use to help select patients. that are willing and able and eager to do PRP, and it gives you sort of something you can sink your teeth into to say, look, here, this is backed up by some pretty good research. If you're just joining us, welcome. We got 55 people on the call. A little bit about sports medicine, ultrasound. Remember, we've got a PRP course in Dallas, and we've also got a podiatry course in Dallas. There's the prices. Let's move on to the material. All right, so lower limb. So what do I do? What are my recipes for cortisone, hyaluronic acid, prolotherapy, or PRP? Well, this whole chart is available in the paid course, but let's look at the recipe for hip joint PRP. So once again, for when I was getting started, actually, when I'm even now, I still ask some of my colleagues, how do I select the best patient? Do you have any experience with peroneus brevis split tears? And I got to ask some of my colleagues. So even today, I'm still asking questions about the timing of some injections. Who is the optimal candidate? Who is a suboptimal candidate? Like, I just don't think they're going to do well. Now, what I've got dialed in for sure is this cookbook. What are you going to do for anesthetic for these injections? What are you going to put in your needle with your PRP? What's your PRP recipe you're going to use in any of these cases? But what do you do post procedure? This is we've run over the past couple of years what we call a mentorship, where we've run 2 webinars a month. And 15, 20, 30 people have signed up for the mentorship, log in, and they ask these questions. And I thought, geez, these are the common questions that come up. I think I should just include this in our online courses. So what we've built is a full-on recipe book. So the hardest hips to treat are the severe OA. The hardest knees to treat are the severe OA. The hardest Achilles tendons to treat are the severe Achilles tendons. But if you follow this recipe, you're going to have your best chance of success. So let's look at what we do for hip joint. Well, what we do in our training programs is we include a 4-panel view for most of our handouts and most of our videos. So this is a skeleton model where you see the hip, the femoral head sitting here, dropping off to the femoral neck. This is what it looks like on ultrasound. This is what it looks like where my hand goes by the patient's lateral leg. And then this is what an abnormal hip would look like. So when I do my hip injections for PRP, I'll usually put my needle here. However, there are some cases where I can see some fluid up here. And in this case, I will drop my needle tip right here, adjacent the articular cartilage on the femoral head, where I can see some fluid. And that's just one of the things I have modified over the years. There's nothing wrong with it dropping it down here. However, if I've got fluid up here, that's where I'm going to go. So that's where I'm going to put it. And then let's watch a video. So this is a gentleman of mine who's he's helped me learn. So if you have any patients who are elderly in your practice, or let's say somebody just can't afford PRP. The way I really got into PRP was I charged lower prices for PRP. I worked with elderly patients who were on a fixed income, and I gave them a good deal on the PRP. That gave them a treatment they were interested in, and it gave me an opportunity to practice on somebody that was willing and eager to try something. So this gentleman, I've wound up injecting his hips 2 or 3 times a year with PRP for the past 5 or 6 years. He doesn't have that bad of OA, but he responds well to the PRP for 5 or 6 months. And so let's have a peek at this. Very bottom over here, that neck around the retina cutting screw. So again, this was our position for setup and injection. As I did the injection, I directed it. That's okay. So again, if you were to inject hyaluronic acid and you're struggling to get it into the joint, I'd encourage you to have your needle step over more. Here. Whereas if you're just doing cortisone or PRP intra-articularly, so as you can see, it's coming through a little bit slow on the webinar, but they're full of videos. Most recently, I've started wearing a microphone, so the audio is even better. Now, here we have the acetabular labrum. I get asked from time to time if I've got a labral tear, do I actually try to put my needle tip into the labrum? I think there are some docs that do that. I'm certainly not in the habit of routinely doing that. I've never seen any studies to show me that gives a superior outcome. So if anybody has any studies to say that's a better way to inject, if you've got a known labral tear, you can identify it under ultrasound and you can get your needle tip in it. If anybody's got studies that show me that I should change my practice, I'd love to see them because I always want to get better results. Now, what are we going to do with greater trochanteric bursa? Now, I'm not usually going to inject PRP into the greater trochanteric bursa. Why? Because I always want to focus more often on the gluteus medius tendon and the gluteus minimus tendon, and a lot of times actually the iliotibial band overlying the apex of the greater trochanter. So let's move on to, so this would be the apex of the greater trochanter. This curved surface here is the curved surface of the greater trochanter, and this concave feature is where the gluteus minimus tendon attaches. And so anytime you see this curve here, that's where this is going to be the minimus, and this is anterior. Now, a lot of my patients will point to focally on the most lateral aspect of the greater trochanter as the maximal point of tenderness. So in this case, I will inject a bit of the medius, a bit of the minimus, and then I'll inject into this portion of the iliotibial tract overlying the apex of the greater trochanter. So how about the posterior band of the glute med? Well, I rarely inject people who have short-term pain. I don't usually inject anesthetic into the hip joint. However, when I get to the min or med, I will inject a small amount of dilute anesthetic. The more full strength anesthetic we put into these tissues, the more it inactivates growth factor release. So if I do anything, and I've chatted with a bunch of people who do PRP, and this sort of dilute lidocaine, where you take a normal saline syringe. So in my practice, I can get my hands on these 10 milliliter syringes of normal saline. I'll push out maybe 1 or 2 milliliters, 1.5 mils, and then I'll pull up 1% lidocaine, and then I'll inject only a tiny amount to where I think the patient will be able to tolerate it. If I think the patient can tolerate a procedure without any anesthetic at all, I'll do it. If I don't think the patient's going to do it, tolerate it well, this is my recipe. Now, of course, ropivacaine is probably going to be the best, most friendly to stem cells and to platelets, the most friendly anesthetic you can get your hands on, but it also runs about 10, 15 times more expensive. So I'm just in the habit of using dilute lidocaine. I think you can make an argument to do either leukocyte poor or leukocyte rich, whether it's red or yellow. I will usually start somebody with a yellow PRP. So there was a great slide that Craig had in there, and it was high concentration, low inflammation. So I think if you got somebody who's new to PRP, who might be a bit more timid, I'll use a lower concentration, less inflammatory PRP like the yellow. If I do want to, if they then come back for the second or third and I want to dial it up a bit, then I'll make sure I add a little bit more of the red. What would I normally do? Post-procedure, I would use the Victoria Institute for Sport assessment of the gluteal tendon patient-reported outcome measure. Patients, in my experience, are wonderful at answering the question you put in front of them. Are you any better? And they will go, no. And we go, okay, how do we base that? What do we base that on? They say, well, I still have pain at night when I sleep sometimes. And I go, geez, I don't have anything to discuss with them. I really wish I had done the patient-reported outcome measure prior to the PRP injection. So for the glute med, in Melbourne, Australia, a group of tendon PhDs, they're literally physiotherapists that they churn out PhD physiotherapists who are excellent at tendon research. They've done these amazing patient-reported outcome measures. So you can say to the patient, look, prior to your treatment, your score was this. Now you're at 2 months post-treatment, your score is this. So I know you are still reporting some issues, but look how much your score is improved. Now, if their score is the same, well, now I know, like, all right, here's your options. We can hit it again with PRP, or we can give it some more time, or we can try something else. What would you like to do? And they say, well, you're the doctor. What would you do? I'll say, if this is me, you've had this 3 years, you've done 3 cortisones, you've got marginal improvement with PRP number one. We got to hit this again, and we got to double down on those exercises. We got to improve your diet. We got to, get you going to bed on time. We got to stop you smoking or whatever. So I think the patient-reported outcome measures are a super important way of communicating with patients. I personally will give almost everybody a Tramoset or a codeine for the first time they have PRP into a tendon, because I've been burned enough. I do not want to have patients come back and say that was the worst pain of my life and I didn't have anything to rely on, and I went to the hospital and they just looked at me like I didn't know what I was talking about. So that's my strong advice, is to at least consider giving them something at least the first time. If they come back in and say, look, it wasn't that bad, be like, hey, do you want any more Tramoset? They're like, no, I think I'm good. I don't need any more. I will not immobilize them, obvious, for a hip. That's going to be tough. I will have them return to their activities of daily living the next day. Obviously, I'm not going to say like lie in bed for 5 days. I'll return them to physiotherapy around the 1 week mark. And then, well, how about returning to pickleball tournament? I'll be like, how am I going to make this decision now when I've just done the injection? I say, do you have a physiotherapist you're working with? And they'll say, yeah, I do. And then they say, I've been working with this physical therapist on lots of different things over the years. I'll say, great. Perhaps your physiotherapist at a 1 month mark may be in a better position to answer that question about returning to sport than I would be right now. So, and your physiotherapist can like reach out to me at any time. So I really want to make sure I don't alienate the rehab team. Definitely include the rehab team when appropriate. And if you ever have a difference of opinion with the rehab team, please, please, please don't throw the physio under the bus. There's lots of times I've been thrown under the bus as a medical doctor, and it's not a nice place to be. Now, when am I going to repeat? It's personal. And the more docs I talk to who do PRP, the more they also tell me the same thing. They personalize it. They don't put it on an absolute schedule that everybody gets the same treatment. So my personal plan, as I say, look, let's talk again in 6 weeks. Based on how you're feeling, we'll probably plan a second one at 8 weeks. But if it sounds like you're doing great, maybe you don't need one again. That doesn't mean you're healed forever. It just means that maybe now isn't the right time to do the additional treatment if you feel like you're 40% improved. Maybe money is a bit of a barrier. So we just play it by ear. So this is an example of a gentleman who had ruptured his quads tendon. And then I was doing some PRP for his quads. He had seen the surgeon. Surgeon said, I can't believe how well you're doing with this ruptured quad tendon, meaning like 80% of his tendon was ruptured. I can't believe how well you're doing. If I had done surgery on you, you wouldn't be doing this well. So go back to Frank and get a couple more PRPs in the quad tendon. He came back for a second PRP in the quad tendon. And he said, I felt something snap in my butt and I don't know what it was. So I scanned him and he had ripped off his glute med tendon. So I don't exactly know why this gentleman is popping lots of things at this age. There's lots of possible reasons, but I don't know why. He responded well to the PRP in his quads tendon. So of course we did PRP to the glute. Sorry, I don't know if I just misspoke. He responded well to the PRP in the quads tendon. So we certainly did PRP to the remnants of the non-torn glute med, and also over the portion that was torn and pulled away. So we can see the needle coming in. Well, you can barely see the needle come in.
That's it.
So I just asked him, I said, how close was that needle to the pain you feel? So the downside of doing anesthetic ahead of time is you may not be able to ask that question later. So if you are going to do anesthetic to this area, you've got to ask that question before you inject any anesthetic. And you put your needle in the spot and say, does this feel like I'm close to your pain? And they say, what do you mean? I say, does this feel like it's at the epicenter of your pain? Is this your pain? And if they say no, I keep fishing around looking for where their pain generators are. A lot of time, the pain generator is not at all where the tissue's torn. It's where, so for example, if this is the tear, sometimes I'll put the needle tip right here and they say that's not it. And I put my needle tip over here and they go, oh, that's the sore spot. So it's the remnant tissue that's still attached that's having, atypical strain forces go through it. That's actually the painful tendon. So that's another part of the technique that we try to teach in the course that is an important part for your practice to make sure you can find the tissue that's actually painful. Now, if you are in a practice right now where you're not using any ultrasound, I'd be shouting at the screen, I can't see your needle. So, and I think that every single day I'm doing injections. I probably do 20 injections a day. Every single day I'm like, man, why can't I see my needle? So the challenge is with ultrasound, if the beam's coming down like this, the greater the angle of the needle away from the ultrasound beam, the less likely it is you're going to see it. The flatter the angle is, the more likely it is you're going to see it. At least I can convince myself of this when I'm doing these injections. Now, in this one, I can see my needle pretty darn good there. I can see my needle pretty darn good down to here. Beyond here, the tissue starts to steal the ultrasound beam energy away from being able to see my needle. The needle tips right there. I can convince myself that I am within millimeters of my target. And that's the beauty of the ultrasound. Because if I was trying to do this blind, I would just go around and poke around until I found where he was sore. I'm not arguing with that technique, but it's certainly not high tech, 21st century, amazing theater for the patient. I think in medicine, our job is to reassure the patient that we're doing what we said we would and we're taking care of them as best as possible. And I think that's one of the most amazing things with ultrasound. Even if you can't see your needle the whole time, it's this great production for the patient to be able to see that you're using top level technology, and there's always going to be glimpses where you can see, there we go, there's the needle, and the patient go, oh yeah, I see the needle too. All the patient needs to do is see the needle once, and they'll be convinced. Knee joints. Now, I do all my knee joints into the suprapatellar recess of the knee joint, so just proximal to the patella. So what's my personal recipe? I will grab a 10 ml syringe. I will inject usually, 6 or 8 milliliters. I've injected up to 50 milliliters of PRP into a knee. That was an unusual case, but we'd tried several different things, and I just had to keep trying something because this gentleman he refused a knee replacement, and cortisone wasn't working, and hyaluronic acid wasn't working, and saline wasn't working, and lower dose PRP wasn't working. So I got up to 50. It didn't help at all, but it was worth a try, and he thanked me for trying. Maximum amount would usually be 50, and again, I think this is quite a lot. Normally 8 is what I go for. I do not have a perfect recipe to be able to help you find who's going to respond to PRP. I had a guy in my office today who had responded great. 55-year-old guy, mild patellofemoral osteoarthritis, anterior knee pain, just like you'd get with with patellofemoral pain syndrome. And he was in the office a year ago, and he had an injection of Durolane, and his knee was amazing. He came back to see a doc, and he said, my knee was so good with that. I really want to try other stuff to see how good other stuff is. We did a PRP injection with one of my colleagues. He came back for the second PRP today. I said, how's your knee? He said, no change at all. I'm like, the Durolane was better. He said, the Durolane was way better, but I'm super eager. I'm super keen. I've got a health spending account. I really want to see if this does something else. So my answer to him was this following. It might be that the Durolane does best for your knee. It might be that the PRP does something different. So I want you to go out. We're going to do the second injection today of PRP. I want you to go out and snowboard 2 or 3 weeks from now. I want you to get in 3 snowboarding sessions between now and the follow-up in February. And I want you to tell me if after the snowboarding sessions, your knee does not swell, and your knee does not ache. Because this could be a case where the Durolane's great for one part of the year and some of the symptoms my patient's having. And the PRP, if we add it to the hyaluronic acid, gives additional anti-inflammatory benefit. So sometimes it's an either, sometimes it's an or sometimes it's both. And that's where if you follow this system with willing patients, you follow their WOMAC scores through the activities that are important for them, you'll be able to find people that respond well to different treatments. So what do? I go to the proximal pole of the patella. I look for the quadriceps tendon. I look for the femur, and I look for the black space of fluid that's between the suprapatellar fat pad and the prefemoral fat pad. This is an example of a normal amount of physiologic fluid. And this is an example of a really big effusion. So now the question that comes up, do you drain a knee effusion before putting in PRP? And the answer is absolutely. I drain the effusion because I don't want my PRP that I've just concentrated to get watered down by this really watery knee effusion. Here's an example of me using a handheld device and doing an injection. This was an atypical approach that I wanted to capture on screen. This is somebody where I wanted to demonstrate a little bit of fluid on the medial patellofemoral joint where I pop the needle in place. Now, again, if you don't use ultrasound, you will be able to see, even if you don't use ultrasound, well, I thought we'd be able to see the needle great, but there we go. We got a good view of it there. And as we inject that, you see it fills up that synovial fluid in that medial gutter. Now, I'm on a webinar right now talking about PRP products with a company that sells an ultrasound product called WeSonic. Here's what I will tell you about the handheld ultrasound products you will find on the market. The handheld ultrasound products on the market are not a bad way to get in the game. Like if you only can scrape together $4,000, let's get doing ultrasound. Absolutely. A handheld product will get you there. But here's what I will tell you. Almost everybody who starts their journey with a handheld ultrasound machine will within 1 or 2 years go, man, I just cannot see my needle as well as I could with my neighbor's $20,000 machine. Or they say, there's battery problems and there's software problems and this thing overheats and it just doesn't last that long. And I will tell you this, I have had many times where I have turned on my handheld ultrasound machine in the clinic because I use them. I use these in my training programs because people want to see what they're like. So I use them in clinic from time to time. I've had lots of times where I turn on my handheld ultrasound machine and I get a screen that says your machine needs to be updated. And I hit update and I pray to God that it does it quickly. And on 3 separate occasions, it's taken more than 2 hours, no joke, more than 2 hours to update. So if you have PRP cases where people have driven into town, you got back to back to back to back PRP cases, and your handheld ultrasound machine doesn't update, you're screwed. Like there's nothing you can do. And this is not something that's going to happen with a high quality, higher cost for sure, but a high quality, high resolution, dedicated ultrasound machine. So I'm not saying you can't start with a handheld, but what I'm saying is make sure you shop around and have a look at a really good, high quality, stable machine with good supports, with a long warranty. These handheld machines come with a 1-year warranty, which means that 13 months, if your machine dies, you're pooched. So the WeSonics, and Craig can correct me on this later. Maybe we can fact check this, Craig. I'm pretty sure the WeSonics have 5-year warranty on the machine and on the probes. And that's kind of become an industry standard, and the handheld machines do not offer that. So
Yep.
for MCL tears, when I look at an MCL tear, what I'll do is I want to see if the MCL is thickened. An MCL tear will be thicker if it gets torn. I think MCL tears are a perfect case. They should be PRP'd every single time they walk in the clinic, unless the patient is doing quite well and does not want an injection. And I've got colleagues of mine who take care of professional athletes in town, professional football team, professional hockey team, and they agree on that. So it's kind of a zoomed in view. This is an osteoarthritic knee with an osteophyte here, but this is a thickened medial collateral ligament. I'll put the PRP absolutely at the joint line, but then also fill up the area that is just proximal to the joint line at the femoral attachment. Ankle joint. So ankle joint, this was one today where I did a hyaluronic acid first. If she doesn't respond well, we're going to circle back to PRP. Ankle joint, I will use the FOAS prom. I will inject usually 4 milliliters. I think the ankle joint can take it quite well. And I don't think there's any reason you couldn't do PRP into an ankle joint. Hardware, yeah, okay. If somebody has a hardware in it from actually, let me take that back. If people have an ORIF of a distal fibular fracture, or they've got yeah, I guess that's probably the most common one. I think these are perfect for PRP. PRP is used to treat skin infections. It's used to treat burns. It contains leukocytes. These are all things that fight infections. So if anybody's needs an ankle injection because they've got some hardware in their ankle, they've got some arthritis, I mean, definitely check with the orthopedic surgeon first if you can. However, like the likelihood of infection from a PRP injection is almost nothing compared to what a cortisone injection, an immune suppressing injection would be. So how do I do these injections? I do these from medial to lateral. So here's the medial malleolus. The ultrasound probe is lined up on the tibialis anterior tendon. We can see the tibialis anterior tendon on the normal ankle over here on the left. Here's an example where the patient actually has a bit of an effusion, and I drop my needle tip right down to the talar cartilage and inject. Plantar fascia. Oh my gosh, plantar fascia. Like I said, this is the injection. This is the PRP injection that I dislike the most out of them all. Let's be honest. I don't know anybody who loves doing plantar fascia injections. If you love plantar fascia injections, put your name in the Q&A. I'm going to send all my patients to you. The reason why is it's a really painful spot. They can't get away from it. It's very painful. I will always do a small amount of anesthetic. Usually do maybe 1 mil, 0.3 into the skin along the needle pathway towards the plantar fascia, maybe another 0.3 or 0.5, and I'll put maybe 0.2 or 0.3 into the plantar fascia itself. Because the patient has to be able to tolerate a 25 gauge needle and putting in 1.5 or 2 mils of PRP into the plantar fascia, they get really sore. I definitely give them Tramoset or codeine, in some cases Percocet. And if I think they're going to have a high amount of pain, I'll boot them for 2 to 3 days. If they've had it for 5 years, I'll boot them for 2 to 3 days. If it's moderate plantar fascia and it's wintertime right now, we got black ice outside where I am. I'm up in Alberta near the Rocky Mountains in Canada. And I do not like booting people or putting people on crutches in wintertime. So this is a normal plantar fascia over here on the left. Anything under 4 millimeters is normal. Anything over 4 millimeters is abnormal. So that's my presentation on sort of lower limb protocols. Again, a fair amount of that stuff you can get in our free PRP course. The online paid PRP course has everything. The live PRP course in Dallas, February 8th through 9th includes not only the discounted live course price, but also includes the online course at one price. The podiatry ultrasound course has cadaver training. So here is the agenda for day 1 and day 2 of our PRP workshop. We'll run you through a bunch of scanning. These are the most common injections you need to have dialed in first. And then day 2, we're going to run through mock mock practice, best practice mock patient encounters. Practice making sure you know how to identify the best vein, whether it's antecubital or whether it's forearm. I had to do brachial artery draws sometime, like 2 times, but I'll show you how to find vessels, find nerves, so you can do blood draws painlessly. We'll show you how to produce the best PRP using the Transcend kits. And then there's going to be an ultrasound scanning for PRP practical exam at the end of the day, making sure you are super comfortable scanning and doing your patient setup, and where's your tray going to be and where's your machine need to be for all these, for any of these injections that you want. The podiatry course, once again, covers the top 20 injections, including on day 2 cadaver practice. Of course, if you're not ready for a live course yet, please hop on and find what I think are the best free courses on the planet. I've seen a bunch, and I think that a lot of them just don't deliver what you're hoping they will. So please take advantage of our free courses. And don't just remember that our free PRP course does include all these patient-reported outcome measures. So if you really need to grab a bunch of patient-reported outcome measures, feel free to hop onto the free course, because the problems are in there. The paid course, again, has 25 demonstration videos of injections. Craig, we're almost done. If you're ready to hop back on, and we'll do our Q&A now. And I don't think you can find better demonstration videos by YouTubing it. In fact, I know you can't. And if you can find a better one, let me know, because I want to copy their technique, because I'm always looking to make our stuff better.
Perfect. Can you see the Q&A right there in the chat?
I should be able to. I'm going to hit Q&A, and I can. It looks like it's loading. All right. Yes, absolutely. So I see that Charlotte added in. I'm going to stop sharing here unless yeah. So I see a comment that Charlotte had posted in, probably from another user, saying plantar fasciitis is symptom results from instability of the ankle, sinus, tarsi, and spring ligament. Absolutely. That sounds like a prolotherapist and a podiatrist who's near and dear to my heart. So I started training as a prolotherapist who got taught to improve stability of the ankle with the ligaments, exercises, treat previous inversion sprains by injecting the sinus, tarsi, and spring ligament. And absolutely, and I got nervous. I'll tell you, I got nervous injecting in and around that spring ligament till I had ultrasound. So I absolutely 100% agree with your comment. Some of the other questions there, I'll go to the earliest one. Is there a comparison between PRP and 5% dextrose? Oh, as probably regarding, I'm supposing that question was regarding my recipes. I will tell you that I monkeyed around with D5W injections for an awful long time, and then I kind of got away from them a bit. It was just my practice style. I don't think there's any reason you can't use them, but I do not have a good comparison between PRP and 5% dextrose. But what I will tell you is PRP I can use absolutely anywhere. 5% dextrose I tended to only use in sort of subcutaneous nerves or peripheral nerves, carpal tunnel, tibial nerve, stuff like that. Looks like the study was 15% dextrose and lidocaine for the plantar fascia study. Okay, yeah. So thank you for Charlotte for copying and pasting that comment into the Q&A. But yeah, I'm glad you caught that, because I made those patient handouts maybe 5 or 6 years ago, and the details certainly, the finer points of each of those patient handouts eludes me. So, I've gotten in the habit of using 25% dextrose on all body parts for prolotherapy. And I know there's going to be some prolo docs who say, nah, you really want to use 5% in the right spot, 15% in the right spot, and 25% in the right spot. And I think that's a really good way to go. Prab Bassi asked, what are my thoughts on interosseous PRP for high-grade osteoarthritis? Prab, I think that is a great question. At the American Academy of Orthopedic Medicine, I'm on the board of instructors, and we teach stem cells, we teach interosseous procedures. I think there's some really good studies looking at interosseous bone marrow aspirate. for high-grade osteoarthritis where you have MRI-proven bone marrow edema. I've not seen nearly as good studies for intraosseous PRP. And I would say that if you did want to do intraosseous PRP, just make sure you are doing it the right way in a surgical facility with 100% sterile prep. But yeah, I think it's certainly the way of the future, I think. I've just clicked on the chat, and so I am looking at a couple other things. It looks like those are the only questions that we got. One thing that I think is worthwhile asking Craig, and I don't want to put you on the spot here, but I might as well. Are you able to comment on the price point for the Piloter and the Navi that you've got currently going into 2025? Because the Piloter is exceptionally priced because like I say, people will come to me and say, Frank, should I buy a handheld or should I buy a Piloter? And I'll say, well, let's look at how you're going to use it. How long do you want to get out of the device? Do you want somebody to stand by it with a long warranty?
Yeah, so great question. I appreciate it. Everyone that's on this webinar and everyone that comes to the live training, Dr. Johnson's already discounted the course for everybody. So this is how it works. So that $1,295 goes for the course. If you want to buy a Piloter or a Navi, which the Piloter is a 13-inch touch screen, color screen. It's great. It's portable. It comes with 2 transducers, linear and convex. It's that discount that you pay, or that course fee that you pay, will be discounted off the cost of your Piloter or Navi. So you can come to the course, and then you can apply the course fee toward a credit in purchasing your Piloter or your Navi ultrasound. And so the Piloter is under 20K, and so if you add another 1,295 off, it comes with a cool carrying case as well. So if you have multiple clinics, it's easy to go. If you want a cart, we can put the cart in there as well. And so these are just kind of the 2 things that we have going on that will help you out in a live hands-on training course.
5-year warranty.
5-year warranty.
And that about 20, just under 20K, you say for the Piloter,
Yep.
get 2 probes, linear and curve. Is that right?
Correct.
That like I say, there's going to be a lot of people who get into the ultrasound game with a handheld, and don't get me wrong, there's a time and a place for it, but there's also I think a real good argument to be made for saying, look, I think this is the future. I think it's what I want to do. Let me get into the game the right way. Now, Craig, it's Christmas coming up, and I just spent some money on Black Friday stuff as well. I don't know if I got 20 grand left on my credit card. Do you have partners for leasing, or how do people do that?
We do. We've got a partner with called iLease that you can go through, and it's basically a lease to own, and we can partner you up with that as well. So we got financing options that we can provide as well for those people.
So
and just to
when I
say
bought my
this,
first,
just to say this course, everybody, this is a small course. So when we say hands-on, you're getting hands-on. I think what are we filling the live one with? What's our maximum, Dr.
it's
Johnson?
well, it's 1 machine for every 2 participants. So I've
Right.
seen a lot of courses. I've taken a lot of courses where it's 1 machine, 4 participants, and an instructor. So the instructor holds on to the probe the majority of the time. The rest of the time, you got to fight with 4 other people to try to get hands-on time. So I refuse to structure our courses in that way. So every single pair of students gets a machine.
Right. So it's a great course. We will send all this out to everybody. And if you were on this course, be on the lookout for an email. There might be some additional discounts that we may offer if you're interested in PRP and ultrasound. We can do package deals. If you're just interested in PRP, we can do some discounts as well on that one. So be on the lookout in your email for that coming down. Any other questions before we say goodbye?
Yeah, Yeah, there's a
Yes,
few
we
things.
actually do have a few in the Q&A.
Yeah, so I can see. So there's one from Patrick. Any concern about the so for knee joint PRP injections, any concern about the PRP not spreading into the knee joint if I place my needle tip in the suprapatellar recess? Um, uh, Patrick says, I've read that in 15% of the patients, the supratellar bursa doesn't communicate with the rest of the knee joint. When I ask surgeons this, they look at me like I've got two heads. So wherever, but Patrick, don't get me wrong. This is not the first time I've seen that comment and that number quoted, but I think it's probably much higher than reality. I think probably in 2 cases I've seen it not spread into the suprapatellar injection not spread into the knee joint, and it's almost always when someone has had 2 or 3 surgeries on their knee and they've got fibrosis of the synovium where their suprapatellar fat pad and their prefemoral fat pad are fibrosed. So in that case, it's almost like an iatrogenic failure. But yeah, every time I ask surgeons, they say, "No, man, I stick my scope in there and I can see well proximal to patella." No, I don't think that's an issue at all. Laura asks if it's possible to add links to the info about the ultrasound systems. I think that's a good idea. And then David asked me the difference between Piloter and Navi and price and features. So Craig, if you can get the price ready for the Navi. I have used both machines a lot. We're going to shoot some instructional videos for each of them. So the Navi is a lot larger. It's on a super cool, amazing cart that my patients love. It's got a battery operated up and down. It's higher processing power, higher end probes, and 24-inch screen.
20-inch screen, I
20-inch
think.
screen. But it's super impressive device. But once again, I think you're getting a really good product at a really good price point with the Piloter as well. What's the price on Navi there, Craig?
The Navi will be right under 30.
Okay, with 2 probes.
Yeah, 2 probes, cart, everything. Same warranty, bigger screen. If you can see my screen, the Navi's right here. You can also go to our website and you'll see all the Navi, and we'll send out information on pricing and talk to each individual who's interested as well. And then above this is the Piloter. It's a little more mobile unit than the Navi.
Yeah, if you are somebody, I work in 2 different clinics, and so for me, moving the Navi around clinic to clinic wouldn't really be practical. I would damage it at some point. So if you work in 2 clinics, Piloter is probably a better choice. If you are, if your exam rooms are quite snug, Piloter is probably a better choice. But if you can, if those 2 things aren't barriers, then absolutely have a look at the Navi.
Perfect.
Peggy asked me if there's going to be a hands-on PRP course in Toronto. That is a great question, Peggy. And I will Google that right now because we're running 23 events next year, and I cannot remember what we're doing in Toronto this year. And Laura asked if you sell and service in Canada. I don't think you guys do. However, WeSonic does have a presence in Canada, and Craig is, you talk with the head office in Toronto all the time, don't you?
Yeah, we'll talk to Jackie up there.
Yeah. Cool.
All right, perfect.
Well, we're 7:15. Thanks so much for attending, everybody. And I think this is being recorded. And once again, if you feel like I went fast through everything, like gosh, it is a lot to cover in a small amount of time. But I wanted to demonstrate to you what I think a really good course should be, including videos, patient selection material, pre-injection stuff, what should be in your needle, and post-injection care. So I hope we've at least accomplished some of that for the lower limb today.
Yep, perfect. Hey, well, thank you everybody for joining our webinar. Thank you, Dr. Johnson, for all your expertise that you show with us, and look forward to emails for our next webinar that's coming out. Thanks, everybody.
Thanks so much. Bye-bye.